record and live stream. Give me one moment, take care of some tech issues. If you haven't introduced yourself in the chat, please do that now. Please add your name, preferred gender pronouns, where you're from. So that could be city and state and the indigenous people's land that you're occupying. And if you're part of an organization, please add that as well.
And Jessica, can you hear me?
Yes.
This is Brandi. I just wanted to point out, I think it'd be good to tell folks, like if you can't add your stuff in the chat because you have a disability like low vision or something like I do myself, no worries. I don't know if we can like let people that are unable to do that speak out loud so they can introduce themselves or something like that.
Yes. Thank you so much. I was just getting to that. I appreciate you reminding me. So yeah, if you can't introduce yourself in the chat, let's take a moment now. Brandi, do you want to start?
Sure. My name is Brandi. I am a fat, low vision, queer attorney in San Francisco. I live in Oakland and I'm on Ohlone land, and I am with Independent Living Resource Center, San Francisco. I'm the legal director there, and I'm also the legal director at FAT Legal Advocacy, Rights and Education Project, and one of the co-founders of #NobodyIsDisposable Coalition. Thank you so much, Jessica, since I was unable to put that in the chat.
Thank you, Brandi. Is there anyone else who cannot introduce yourself in the chat? Would you like to introduce yourself?
I'm going to introduce myself. I'm Kathy Long. I am blind. I can enter the chat, but the chats are coming in so fast. Yes. I'm not hearing everybody. That I have to turn my speech off because it is just too disruptive. I mean, this is not a good way to do it.
Kathy, go ahead and introduce yourself, and then I'll make a couple other comments on access.
Sure. I live in Pennsylvania, and I'm affiliated as a active consumer of Center for Independent Living of Central Pennsylvania, Harrisburg, Pennsylvania. I'm going to mute.
All right. Thank you so much. Glad to have you. So couple notes on access. Just a reminder for those who came in, please choose interpretation in English or Spanish at the bottom of your screen, either the globe or hit more. And then as far as collective access, we all want to share the responsibility of making sure today is as accessible as possible. So we have 2 ASL interpreters. Thank you to Norma and Kat for being here. And we will have, they will be sharing the spotlight. You can also pin them, whatever is easy for you. If you have questions or any issues with that, please let us know, ideally in the chat, if that is accessible to you. We do have captioning today. And if you go to the bottom of your screen, usually it's under more, you can choose show subtitle. We also have a link if you prefer to see the captions externally. And I believe Shaya will share that link in the chat in just a moment. As far as making the chat accessible, we do have the chat because we know it actually makes things more accessible for some folks. And it's a way that people can share comments and questions throughout. We will be reading things out from the chat when there are important questions and comments that are shared there. And we will send the full chat later to all of you who are here today and all who registered. And I want to invite people to share other access needs or things that you may notice. Is this an access question from a 717 number?
Yes, hello. My name is Mark Pickens. I am from Harrisburg, Pennsylvania. I'm a consumer advocate with the Center for Independent Living of Central Pennsylvania. I live in, I believe it's Susquehanna land. I am on my smartphone, and this is a question related to interpretation. I don't have access to the chat, but also for hearing speakers of multi-languages. I was wondering if there was a number that I could press on my phone to give me the English interpretation, because that's what I have accessible.
Right.
I also have low vision.
Thank you so much for bringing that up. So some of us are currently putting some pressure on Zoom to add an interpretation option to the phone. It seems very doable, but they have not made it possible. So unfortunately, those of you on the phone will not be able to access language interpretation. I think the folks on the phone right now are English speakers. Let me know if I am wrong about that. Most of the program will be in English, for better or for worse. And so we will do the best we can, making it as accessible as possible to everyone. All
Okay,
right.
thank you.
Thank you so much. Any other key access or tech issues that I may have missed before we go on?
Yeah, if I could, George Gilmer. I guess all these people are mentioning, we're kind of from the same area, so we might be a little behind the curve on IT. I guess we need more IT here. But thank you, I'm having technical issues too. So introduce myself. I helped to organize the state of Pennsylvania for the Americans with Disabilities Act. I was community organizer, and knew Ed Robertson and knew Justin Dart. So one of the older advocates probably here, and seeing the problems that have happened for decades. So I'll take you way back when we were at the White House after the ADA was signed. We weren't going to get our rights for another. It was portrayed not unlike the blacks for another 100+ years. We really weren't going to get them. And I kind of decided at that point in time for us to really stand out. We all needed to have a place to meet together and have a national disaster of the problems that we're not having for their inability for recognition.
Okay,
Sorry,
thank you
go
so
ahead.
much. I'm going to move us along because we have a lot of speakers today. We will have small groups, so we'll have a chance to talk a little bit more. I also just want to name, so today's Care Rationing Forum is in the place of the Organizers Forum, which is generally a monthly call sponsored by the National Disability Leadership Alliance. And it is designed to support and expand community organizing among disability communities. And part of the purpose of the Organizers Forum and of our call today is to explore the relationship between ableism and other forms of oppression, that we see strong intersections between ableism and racism and ageism and fat phobia and classism, right? And that we know that disability communities are broad and are made up of people who have all of these marginalized identities, and that it is that people with those multiple identities are the most marginalized, even in disability spaces. And so today we're going to be very aware of those intersections and how we can really act in solidarity with each other and be present with our full identities. So just a word on why we're coming together. What is the issue today? And then I'll be able to turn it over to our speakers. Since the beginning of the COVID pandemic, we have seen a disproportionate impact on older people, people with disabilities, higher weight people, and people of color. But our groups haven't been talked about, right? We've really been seen as expendable. And as we saw hospitals get low on ventilators, on ICU beds, on staffing, there were a lot of ways that seniors and people with disabilities and higher weight people were deprioritized for care. That people said, you know, this person basically isn't as important as this other person. And so they're not going to get that ICU bed, or they're not going to get this treatment. And fortunately, we all raised some awareness of care rationing and pushed back against policies that sanctioned that. Then, you know, the vaccines came out, things got a little quieter, and now we know it's happening again, that there are several states that have instituted what are called crisis standards of care, which we'll explain more later. And there are states that are at risk of not getting the right care and treatment to seniors, people with disabilities, higher weight people, and disproportionately people of color. So one of our questions for today is not only what's happening in these states, but how can people around the country, how can disability advocates and other advocates around the country support people in states that are at risk of rationing care? So on that note, I want to introduce our speakers. I'm just going to start with names and organizations, and I'll invite folks to say a little bit more about themselves as well. So today we're going to start with Reyma McCoy McDeid, who is the relatively new executive director of the National Council on Independent Living. And Reyma will be talking a little bit about what is care rationing all about. Then we're going to hear from Silvia Yee from DREDF, Disability Rights, Education, and Defense Fund. And Silvia has really been at the lead on a lot of the policy issues about crisis standards of care. Then we will hear from people in a couple states that are dealing with care rationing. So Mel Levitan from the Idaho State Independent Living Council to talk about what's happening in her state, and Doug Toelle from the Statewide Independent Living Council of Alaska to talk about what's happening there. And then we will get to hear from Brandi Senziak from Independent Living Resource Center, San Francisco, FLAIR, Fat Legal Advocacy, Rights, and Education, and the Nobody is Disposable Coalition to talk about the relationship between ableism and fat phobia, and to talk about a very exciting survey that is being launched, and then we can talk about how to distribute it. So then we're hopefully going to have a little bit of time for small groups to do some exploring with each other how we can take action to really come up with some specific next steps. And then we'll return to large group and close. So on that note, I am delighted to turn it over to Reyma McCoy McDeid.
This is Reyma speaking. Thank you, Jessica, for inviting me to participate in this amazing event and for coordinating this event in the first place. Obviously, care rationing is a pervasively important topic of conversation for all of us for a variety of reasons. And so I'm going to kick off our talk regarding care rationing with kind of some overarching points for us to consider as we embark on this meeting this afternoon or this morning, depending on where you are at. Quick visual description of who I am. So she, her pronouns. I am a Black woman, early 40s, seated in my home office, got brown natural hair, I'm wearing tortoiseshell glasses and an orange top. Got various pieces of artwork behind me. I'm the executive director of the National Council on Independent Living in Washington, D.C., as Jessica pointed out. All right, what is care rationing? You know, I think we all know what care rationing is, and we're all cognizant of the fact that there are a variety of definitions of what care rationing is. And some of those definitions can feel a bit like a sadistic boogeyman, for instance. You know, medical rationing is a means of making the systemic murder of people deemed members of the surplus population perfectly legal. You know, that can certainly be seen as a definition of medical rationing. It can be seen as an economic savior by some. Rationing healthcare means getting value for the billions we are spending by setting limits on which treatment should be paid for from the public purse. That's an actual quotation from Peter Singer, who I'm sure many of us are very well acquainted with regard to his troubling philosophies and how they intersect with the disability community. Some folks define medical rationing as a quote unquote necessary evil. And that's the definition I want to unpack today as we come together to talk about care rationing. So the delay or denial of medical treatment to some patients who need it because there simply aren't enough resources to go around, or there's a perception that there aren't enough resources to go around. And so here we have a necessary evil definition again, and it's an argument that operates with a few different premises again. Only some, quote unquote, patients are negatively impacted. And because there's a perception of finite resources or limited resources available in the US healthcare system, it's seemingly inevitable that hard decisions must be made for the sake of the greater good. Now, to your average everyday person, that might sound perfectly reasonable, right? Now, those of us who identify as being disabled, we know from our own deeply personal lived experience, the terrors that we have and do to this day endure for the sake of what mainstream society deems as quote unquote reasonable, don't we? You know, ultimately, care rationing, no matter how we're going to define it, is all about value. The value of human life, who is valuable enough to have access to the world's most advanced medical system here in the United States, and ultimately the value of the dollar over everything else that looms over all of our heads. You know, we often think, so we're talking today about how care rationing conversations intersect with ableism, racism, and all the other isms. And so let's talk a little bit about discrimination. We often think about the root of discrimination being a hatred for a particular population of people. But when we're talking about discrimination on a systemic level, the question begs, is that true? You know, we hear about discrimination in the media, and we see, you know, these very blatant examples like crosses burning in Black folks' front yards, that kind of thing, you know, really overt in your face type stuff. But when we're talking about discrimination from a systemic vantage point, you know, we're talking about how it manifests in covert ways. And those covert ways lead to conversations about what is quote unquote reasonable with regards to who gets access to healthcare and who does not get access to healthcare because of something along the lines of crisis standards or that kind of thing. And so with regard to care rationing, because as we see in issues pertaining to it, the basis form of discrimination, obviously, is the denial of essential health services or treatments based on disability or health status, or subversively other intersections of marginalization that those of us who are members of the disability community who are marginalized in other ways identify with. Nevertheless, the denial of essential health services and treatments has been the default as states and providers have developed crisis standards of care in response to the COVID pandemic most recently. The type of zero-sum decision-making behind these crisis standards of care are felt most profoundly in Black communities and Brown communities, where resources are most limited in medical settings, and where racially based implicit bias compounds disability discrimination, placing Black disabled people most at risk of being subjected to the denial of essential health services. Rest in peace, Michael Hickson. So ultimately, care rationing, care in quotation marks, is exactly what it sounds like. It's about demonstrating how much society cares about a person by determining how much access to life-saving medical services they deserve. The more marginalized a person is by disability, by age, by body type, by skin color, by sexual orientation, by gender identity, by immigration status, by all of those, and then some, the more likely they are to experience a curtailing in access to healthcare in the United States. Why? So that those who most closely resemble the quote unquote default setting for American, quote unquote, may enjoy unfettered access to healthcare, which is artificially rendered finite by the rules of capitalism ultimately. And so I want to be mindful of time, and I'm going to end my comments there, pass the mic back to Jessica so that Jessica can introduce the next speaker. And I thank everybody for your time today.
Thank you so much, Reyma. That was a really powerful introduction to the issue. Thank you so much for being here and highlighting those really powerful intersections. And Reyma also reminded me that I think I forgot to introduce myself and give a visual description. So thank you for that. As a disabled person myself, it's just, I'm still learning and still forgetting things all the time. So thank you for that. So my name is Jessica Lehman. I use she and her. I am on unceded Ohlone land, which I'm realizing I did say, and I'm in Oakland, California. I work for Senior and Disability Action, which is a nonprofit community group building a movement of seniors and people with disabilities. And I am a white woman in my mid-40s. I think you can see the headrest of my power chair behind me. I have short, straight brown hair, kind of a bob. And I am in front of a wall with a framed picture of people rallying behind me. And our next speaker is going to be Silvia Yee, who is a senior staff attorney at Disability Rights Education and Defense Fund, DREDF. Silvia has done all kinds of work on disability access, physical and programmatic access in healthcare, as well as all different kinds of access issues throughout society. And Silvia has been recognized as a really key player on issues of crisis standards of care and care rationing. So let me find Silvia's spotlight and turn it over to her.
Thank you, Jessica. I appreciate the introduction, and Reyma, thank you very much for that really essential framing, which we can all keep in mind as we go through our talks this afternoon. I wanted to give not so much the framing, but just some of the facts of crisis standards of care as they've come to be known in this country. I'm quite confident that 2 years ago, very few of us had any idea of the phrase or what it meant. So crisis standards of care can be, I apologize, I did not give a visual description of myself. I'm an Asian woman. I have black hair that is increasingly filled with gray. I wear glasses and I have tan skin and a stripy top on. So crisis standards of care can be understood as something that is unusual. It's supposed to be unusual. It's different than a so-called regular standard of care. And the regular standard of care that is expected in healthcare in the US is basically giving treatment first to those who need it most urgently. Crisis standards of care, however, happen when the healthcare system is so stretched, so low in resources, and those resources can be ICU beds, intensive care beds, they can be equipment like ventilators, or they can be people, healthcare providers in the healthcare system. When those resources are so low that the judgment is made that the normal standard of care can't be adhered to because the resources will run out. The thought is that there's a need to do something to preserve the resources and to preserve human life. And then that's when crisis standards of care are come into place. They're seen as something that happens at a point in time, a response to some urgent and extraordinary need. But in keeping with what Reyma has said, the fact of such a need is foreseeable in many ways. Maybe not the exact contours. We didn't know COVID-19 existed. We didn't know that a pandemic would occur. But it is foreseeable that from various reasons and for various reasons, there can be such a thing as a great stretching of the healthcare system, whether it happens in a city or a state or in an entire country or in the world. And then that's when we start to put in place some other system and where our values tend to come to the fore. And that ties in again with what Reyma has said. So how does care rationing get sanctioned? The need for crisis standards of care was recognized in the US, especially after 9/11. And after that, what happened in the state of New York, and there was such a stretching of the hospital system there during that emergency. Federal experts worked on guidelines, and individual states have also had their experts determine state guidelines. Often those guidelines are applied are developed thinking about specific situations, such as a flu pandemic or a natural disaster of some kind. So, for example, we see in Colorado, which is not a state that has triggered its crisis standards of care, but it is a state that has triggered a limited crisis standards of care as it applies to staff, because the feeling in Colorado is that there are not enough healthcare personnel to meet the demand. So what happens there when a crisis standards of care is that it's usually determined by a high official in the state, someone like a governor. It's authorized by a governor and then triggered by the highest medical officer or the highest public official in the state. And so you can see that the crisis standards of care are often recognized as something that experts are involved in. They develop it, they work on them, they figure out where and when they apply. But a state's crisis standards of care is guidance only. Usually, in fact, this is all I've ever encountered, individual hospitals and healthcare systems still get to develop their own guidance, and they get to choose just how transparent they want to be with their own specific guidance. So one of the recommendations that healthcare disability advocates often ask for is both disability input into crisis standards of care in the first place as they're being developed. It can't be just a matter of experts when people with disabilities, people of different races and ethnicities are often the ones most deeply impacted and denied treatment under a crisis standards of care. And disability advocates also ask for transparency for crisis standards of care in those individual hospitals and hospital systems to be made more apparent, either to be made publicly available and not just something you find out when you go to a hospital and you find out you're being rationed, or your family finds out you're being rationed because you are unconscious. So along with everyone else, disability advocates only became aware of crisis standards of care after the pandemic started in the early spring of 2020, as hospital systems across the country became strained with the novel coronavirus. That's when a lot of the advocacy that has occurred around crisis standards of care sprang into place. Back in the spring, advocates of 2020, advocates organized and sent complaints to the Federal Health and Human Services Office for Civil Rights. And so at that time, some of the worst crisis standards of care, those that explicitly named specific disabilities and conditions as being subject to lower prioritization for care, or those that took away individualized assessments for treatment for some people with disabilities, or others that gave healthcare officials and doctors discretion for deciding whether people with a lower quality of life could be placed lower on the list for COVID treatment. And as has become more and more known, there's a lot of implicit bias in the healthcare system in terms of disability, with the assumption among most healthcare professionals, amongst many, many doctors, that people with disabilities have a lower quality of life. So all of those actions took place. A lot of coordinated advocacy against crisis standards of care took place in the spring of 2020. Surprisingly, no crisis standards of care were actually triggered in 2020, however. We come now to summer and fall of 2021, and that is when we have had some crisis standards of care triggered. And as much as we fight against crisis standards of care, I think often what we've done is help to improve those crisis standards of care, but it's still extremely hard to know what is happening on the ground, what is happening even before the crisis standard of care is triggered, and what is really happening with people, to people with disabilities when they go to the hospital, whether for COVID or anything else. So for that, I think we are going to go on to some people who are on the ground and able to speak to that. And I'm going to turn it back to Jessica to introduce our next speaker. Thank you.
Thanks so much, Silvia. I really appreciate your expertise on this issue. People should feel free to keep track of your questions for Silvia and others. We aren't going to have a lot of time right now, but we will definitely make sure people get hooked up to get those questions answered. Silvia is definitely a wealth of information. So our next speaker is going to be Mel Levitan. And I feel honored to have been introduced to Mel just, I think, a couple months ago now, as we all started working more on care rationing issues in Idaho and Alaska. And Mel is the executive director of the Idaho State Independent Living Council, as well as a member of the State of Idaho Disaster Medical Advisory Committee, which developed the state's crisis standards of care. And let me bring up Mel Levitan.
Great, thanks, Jessica, I appreciate it. My pronouns are she, her. I'm a middle-aged white woman with super short, very gray hair that, if you get it in the right light, actually looks blonde. So we'll go with blonde and gray. So as Jessica mentioned, I'm a member of the team that developed Idaho's crisis standards of care. Back, we really started on it in early April of 2020. Having worked in emergency prep and mitigation activities in Idaho for some time, when we looked at the most recently released state plan, had brought to their attention that Idaho didn't have a crisis standards of care. And so we're really ready for that. When they pulled the team together, I was really out of my element. I have no medical background other than being a person with a disability. That gives me my own expertise, but that's really it, no medical expertise. On a very large committee made up of medical experts that weren't initially very receptive to hearing about things like equity. Fortunately, we had some chairs, one of whom was our Medicaid medical director, who actually is very concerned about medical equity and access for people. So anyway, it turned out to be an opportunity, I think, for us to educate them and for them to learn from us. So what's happening now in Idaho is on September 6th, our 10 most northern counties activated crisis standards of care. That is still the area where we see the most significant impact to the hospitals. They remain in a high level of crisis, essentially in the hospital serving that area. Typically, or during blue skies, they're able to refer overflow over to Washington, primarily Spokane, Washington, but that has been less available to them in recent months. The rest of the state followed suit about, I think, 9 or 10 days later. The whole state went into crisis standards of care. And as Jessica mentioned earlier, many hospitals already have their own set of crisis standards of care, or own rules of crisis standards. And that's still true. So I think what some people fail to understand is that crisis standards are advisory. It provides essentially a cover for liability. The smaller hospitals really need those standards. They may not have those written, whereas a larger hospital or medical system does have them. They are harder to get a hold of. You have to ask for them and ask for them and ask for them and ask for them some more. That's one thing that's serving on the advisory committee has been helpful in, is because we've made those relationships, we're able to get access to them a little bit easier, which has been a positive. So I encourage you to get to know those people. What was initially wrong, we got a few things right in our initial standards. It was still full of ageism when first released, and those things have been corrected thanks to a lawsuit filed by Justice and Aging and our state protection and advocacy system, writing several letters to our governor and our director of public health. The two principles, the big thing that hung us up here in Idaho on the crisis standards was related to what they call tiebreakers. Our tiebreakers were based on ageism. How many life years are we going to say? It doesn't say that anymore. It's been corrected to now they simply say, they say stuff. Save the most lives. One thing that's been really challenging is that we've also been very active in getting vaccines to communities. We're a very rural state. And so how can we get vaccines to people? How can we educate people about vaccines? And the balance between science and equity. And that's some of the issues that we have, with doctors on the team, is they'll say, well, you can't question our medical expertise, right? If someone is older, they're less likely to survive COVID. And really our concern about crisis standards is they don't just apply to people who go to the hospital for COVID. They apply to a massive accident on our freeway. A variety of things that happen doesn't just apply to COVID. And so where somebody might have a really good odds of recovering from whatever they went to the hospital for, those folks need to have a shot at getting the critical care that they need, just as anyone else would have. And I think that escapes a lot of people because we're just learning about crisis standards of care and what it means. It's something that's always in place, whether there's a pandemic or not. Those crisis standards are in place. And if there's a large accident on our freeway, or there's a hazardous waste spill or whatever that causes an influx of people to our emergency centers, are we going to be evaluated for care based on our condition physically, or are we going to be somewhat evaluated on the color of our skin, the perception of a disability, Are we going to be evaluated on our response to verbal cues? If I can't hear, where do I rate in that scale? So really being aware that this is something that's in place all the time. And I don't want to take up a whole bunch of time. So I will go ahead and wrap up now. I do want to just touch on one note that's very important. And I think we're still seeing it in Idaho, and I'm sure people are seeing it in other places, is that when you go to a hospital, you have an opportunity to be triaged by medical professionals, and they're going to have their bias, whatever they have, but you're going to be triaged by a medical professional. How many people are in skilled nursing facilities, residential assisted living facilities, intermediate care facilities for people with intellectual and developmental disabilities that never get an opportunity to be triaged for medical care because they have a do not resuscitate order in place? That order is in place, and if they have COVID, they oftentimes are never sent to the hospital for further evaluation. And that's becoming a greater concern. They're also not necessarily tested. Families attach a lot of stigma, we're finding, to someone dying of COVID. So there's some judgment there, which was unexpected. And so I would just really encourage people to look at what's happening in congregate care facilities. Are people even getting an opportunity to be tested and to be treated if they want that and their family members want it? Do they even get to the hospital to be evaluated for treatment? And with that, I will pass it on. Thanks, Jessica. And all.
Thank you so much for that, Mel. Really appreciate it. I wanted to share a couple things that have come up in the chat. Bill Kenyon was saying, history teaches us that policies instituted in period of perceived crisis often become permanent, continuing long after the triggering circumstances have ceased. And it reminds me, Mel was talking about, if there's a big car crash, a lot of people go to the hospital. What happens if there aren't enough resources? And that she has reminded us in other venues that even in states where people aren't talking about care rationing, we could always be one disaster, human caused or natural disaster away from having some kind of care rationing in our own places. And so Silvia Yee was saying, yes, that's exactly why it's so important for disability advocates to be engaged in this issue, even when the circumstances seem to indicate that the immediate danger is past. Sylvia also said, as Mel says, one thing to watch for are crisis standards of care that don't emphasize maximizing life, but maximizing life years. And so many disabled people are assumed that we will have a shorter number of life years. Some of us do have a lower number of life years. And then, of course, there's the subjective part of people judging what is the quality of those years. Bill also added assumptive statements on anticipated duration of life and this is what I was saying, and arbitrary ableist statements about quote unquote quality of life are very dangerous. Aaron Olson said, in usual times, CSOC, crisis standards of care, is called triage. And then Sylvia added, another issue that we found with the do not resuscitate DNR orders is that healthcare workers could assume without checking the record that a person with significant disabilities has a DNR in place. That could just be a mistaken assumption, but it would allow the hospital to stop providing care. And I just want to name how complicated it is that doctors and nurses and other health providers have had such a horrible time during this COVID pandemic. I can't imagine having to see the number of people coming in sick and knowing there's only so much you can do, and having to watch people die when there aren't other visitors that can come in. So I think it's just important to recognize that they're in this terrible situation. And at the same time, that health providers often do have an ableist bias, right? They're trained in this idea that we're supposed to get rid of disease and disability. And some of us don't think there's anything wrong with our disabilities. And so there's just a lot of challenges there, right? And when they have these split-second decisions where they're not even necessarily able to pause and think about it, but have to just do something, then of course those unconscious biases creep in even more. And someone says fat people are often perceived to have fewer life years than thin peers. So thank you for all of that. Let's move to our next speaker, Doug Toelle from Alaska. Doug is a small business owner who spent 15 years as a full-time disability advocate and is now on the Alaska Statewide Independent Living Council. Thanks so much for letting us know what's going on in your state.
Well, thanks. It's I'm a 64-year-old white male with brownish going gray hair and a white beard and a green sweater of some sort. I don't know. And my background's blurred, so we don't need to talk about that. It is 10 degrees below zero outside. I won't show you that, and I'll save you from that. There's an advantage to coming last because so many of the things I was going to say have already been said, and I don't want to repeat them. So Alaska is, the governor did declare, that crisis standards of care, whatever his declaration is. And so most of the hospitals in Alaska have been operating under those. Fairbanks, where I live, the hospital is not. They've rescinded that ability. And I think that the Disability Law Center of Alaska got involved in 2020, like with Mel, and they managed to modify what was already in place. We did have a crisis standard of care at that point. And so the whole introductory part of there talks about not making decisions based on disability or biases. And then smattered throughout the document, it mentions that disability can't be used as a criteria. And I, since I knew I was going to speak here, I've asked around a lot, and I can't find any instances where this document has impacted anybody negatively at this point. And I think a key thing is being at the table, like Mel talked about. And Disability Law Center has been at the table on this document since the start, because once you get into the triage point or the point where you're making decisions, those documents aren't always remembered. One of the problems in Alaska is, as in Idaho, is distance. We have 220 towns and villages that are off the road system. And I am on the land of the Tanana people. COVID deaths among Alaska Native American Indians are significantly higher than white folks. And getting somebody from a remote village to a medical facility, most towns and villages have a clinic, but it may or may not be staffed. Then they need to get to a regional center like Nome or Bethel, places most people haven't heard of. And then from there, they'll go to Anchorage or Fairbanks if they need higher level of care. And then at the height of the pandemic, people have been sent to Seattle and things. So you're adding, a day of time to get treatment. My son is actually a pilot in Nome, and so I called him last night to ask him what he had seen. And he did say that he's seeing more medevacs going to outside of the region. So they're going to Anchorage or they're going to Seattle than he saw before. And I don't know where that airplane part comes into the standards of care. I couldn't find it in there, but that's a huge resource. And I'm sure it's limited. So that is a concern here. Excuse me. So I guess the bottom line here in Alaska is although the governor has declared it, Alaska has the highest, well, until yesterday, had the highest COVID rates in the nation, but we had some of the lowest death rates in the nation. Haven't seen why that is. I guess because it's 10 below and we're tougher. I don't know. So I can't find an instance that they have actually implemented any of these plans. So I guess my advice to everybody is be at the table, pay attention. As I was asking around, I was surprised how many folks with disabilities didn't know what I was talking about at all. So educate folks so that if they get in that situation, they'll be able to advocate for themselves or their family members advocate for them. And I think, you know, the other speakers before me just covered all of my notes here, so I don't need to repeat any of that stuff. So thanks. We can get on to the next, to our groups here.
Thank you so much, Doug. Really appreciate the work you're doing in Alaska. And I think that's an interesting point about the plains, is that care rationing may pop up in ways that we're not always expecting, and that we need to be thinking really broadly about it. So our next and last speaker is Brandi Senziak. Brandi is a lawyer who works at the Independent Living Resource Center of San Francisco. Brandi is also a leader of FLAIR, Fat Legal Advocacy Research and Education Project, and hashtag Nobody is Disposable Coalition. I think a lot of you have probably seen hashtag Nobody is Disposable on social media over the last couple of years. It has been a really powerful way to talk about the lives of those of us who are marginalized in many different ways. And so I want to thank Brandi and others for creating that. And Brandi has really been a key player in the California Care Rationing Coalition and the work more broadly than California in recognizing and pointing out the intersections between ableism and fat phobia, and how fat or higher weight people have really been affected by what is going on with the COVID pandemic and care rationing, and in creating a survey that we're going to be able to use to collect stories. So on that note, I am going to turn it over to Brandi.
Hi, Jessica. Thank you so much. Hi, everyone. So as Jessica said, my name is Brandi Senziak. I'm the legal director of Independent Living Resource Center, San Francisco, and also the legal director of Fat Legal Advocacy Rights and Education Project, and a co-founder of hashtag Nobody is Disposable Coalition. I am a white 39-year-old queer fat woman, and in the background I have a black curtain, and my background is blurred. So I became involved with working on advocating for less discriminatory crisis standards of care in California last March, when Fat Legal Advocacy Rights and Education Project and hashtag Nobody is Disposable Coalition worked alongside other disability organizations in advocating for less discriminatory crisis standards of care. And in the end, we were pretty successful. But as Silvia stated, these are guidelines. Each hospital does have their own policy, and we are concerned about what's happening in the states that are currently facing crisis care situations. We're very concerned about people that are most marginalized, those individuals that are at the intersections of multiple identities. One identity that doesn't get talked about much is weight and size. Fat people face discrimination in healthcare situations constantly, even under the best circumstances, even when there's not a crisis standard of care policy that is being implemented. This is because of people's stigma, as well as the fact that equipment just isn't made for us. Fat people don't necessarily know that they have rights, and they may not realize that they may be protected under disability law and other state, federal, and local laws. Weight discrimination impacts certain communities of color much more harshly than white people and can be used as a loophole for racial discrimination. For these reasons, we wanted to create a survey. We wanted to be able to get people's stories out there and let people know what's going on. So the hashtag Nobody is Disposable Coalition and Fat Legal Advocacy Rights and Education Project have created a short survey from people, a short survey to hear from people that are being denied medical care because of limited medical resources. Responses will be used to help advocate for medical treatment, and as I said, to sort of get the word out and let folks know what's happening. This survey was created to help gather stories for advocacy purposes of folks who are having trouble getting medical care during COVID. So who should take our survey? Please take the survey if you or someone you know had a hard time getting medical treatment during COVID due to limited medical resources and supplies and equipment shortages. And you suspect that part or all of the reason you did not receive necessary care was based on discrimination, including but not limited to weight, disability, race, age, or other factors. Also, please take the survey if you have been delaying necessary medical care because of being at high risk for serious complications if you should get COVID, and you are worried about being deprioritized for medical treatment if you do get COVID. And finally, it would be great if you could please take the survey if you work in a healthcare organization and have concerns about the care rationing policy or how it is being implemented. Please also forward the survey to your networks. We will be reviewing answers on an ongoing basis. Thank you so much for your time. And I will return to Jessica to talk about how we can go ahead and share the survey with everyone.
Thank you so much, Brandi. And did you put the survey in the chat, or can we do that?
We can do that. I will work on getting
Okay,
that.
wonderful. And that survey is in English and Spanish, right?
Yes, I believe we have separate links for the two versions, but I will work on getting that done.
Wonderful. So is everyone going to start immediately in sending the survey by email and social media to everyone that you know in Idaho, in Alaska, in Colorado, in Montana? Like, are there other states that we're thinking about? New Mexico, I think, just started some care rationing, and really wherever in the country, right? But thinking broadly of who we can get this to. So we're going to shift gears a little bit. We were going to do small groups, but we are not going to have time for that. There is a lot to process here, and I just want to acknowledge that. And I apologize for not saying at the beginning, although clearly everyone knows that this is a really hard topic, and I just want us to make space for ourselves. You know, it's been a hard couple of years. I think everyone has dealt with friends, family, acquaintances who have gotten sick, who may have died, and not only dealing with the death, but not being able to be together to grieve, and then to feel that a lot of it was preventable and that a lot of it is based on discrimination and based on ableism and ageism and racism and fat phobia. It makes it really hard. And so I want to appreciate everyone for for being in community. I think learning from each other and being able to share that with each other can help us a lot. And personally, I feel like there's a lot of energy coming from us being able to take action together and feel like we can do some things to make sure that more people don't die unnecessarily, right? That people are treated with the dignity and respect that we know they deserve. So we have a few ideas about how folks can take action. Okay, and so I'm going to go over these ideas, and then we're going to have about 10 minutes, or maybe a little less, for some discussion. We'll do a little bit of Q&A, and if people have other ideas or thoughts on how we can all have an impact around the country, then we want to hear those ideas. And then we'll do some announcements and close. So some of the things that have come up already, one way that folks could help is research. So Mel in particular, Mel Levitan in Idaho, has talked about concerns, and she's not the only one, of course, but concerns about COVID deaths in care facilities. And it's often very hard to really understand what are the deaths, right? That people may not get sent to the hospital. They may not be recorded as COVID deaths, even though they are. And so we could use some research, some people who really know how to do research who can help get some of that data to be able to talk about it. There are other research issues as well. I know it came up in Alaska about people who died, but who hadn't been tested for COVID. And so looking at how do the rates of deaths compare, and if there is a big jump, we can make some conclusions about COVID. So there may be some other research ideas as well. Raising awareness through social media or other means is clearly a big one. I appreciate that. I think it was Doug who was saying that there are so many, even people with disabilities, that don't know what care rationing is, and don't know that it's happening, right? A lot of people who feel like, that was a concern a year ago, but we're out of the woods now. And unfortunately, we're not. I'm just going to make sure our interpreter is spotlit as we switch. Okay. So we need folks who really know how to think about not just, I'm going to share this on social media, but think about a strategy around that, right? Should we do a Twitter storm? Should we have a series of Instagram graphics or stories? Should we be thinking about who can we get to share messages on social media who have a big following where it will really be spread? And in addition to that strategy, we need a lot of people here who are willing to just share it, right? Every time a post comes out, a news article about this, that you will share that so that we can make sure we're continuing to educate people about this. There's survey distribution, right? We started with that we need a lot of help in doing that and getting to key organizations, not just disability organizations or senior organizations, but all kinds of organizations that can reach big numbers of people in states where we have reason to believe that there may be care rationing or where they are at risk of care rationing, to be able to get that survey to the right people and encourage people to turn it in. And of course, we want to hear personal experiences, and a lot of that will come through the survey. But if people have other experiences with care rationing, there are 1,000 ways to share those, and we just need to get those stories out. And we do have a national coalition fighting against care rationing. So we'll also want to hear if people want to be a part of that. So I'm going to open it up. I'm going to ask people to raise your hand because there are a lot of us. So you can, if you're on the phone, you can raise your hand with *9. If you're on Zoom, you can hit the raise hand option. You can try physically raising your hand if that works, and I will try to see that. You can put in the chat that you'd like to speak, and we will get through a few questions and comments. I realized before I start, I want to share a couple other things from the chat, and I haven't been able to keep up with all of this either, but there's some great stuff here that we will be sharing by email later. Someone said it's just the tip of the iceberg. I totally agree. Someone was talking about mask mandates, allowing alternative face coverings for people with certain disabilities, making mouths visible for people who depend on that, who depend on lip reading for communication. What else? There's links to the Care Access Survey. Thank you again to Brandi for that. And then Wendy shares her story. My sister had MS, one of the invisible disabilities. Her many doctors rationed her care due to feeling that she was seeking attention. After so many decades of her care being rationed, she internalized that mindset, feeling that she did not deserve care and rarely advocated for herself, thus rationing her own care. We lost her in April from a completely preventable medical event. This is the true cost of care rationing. I'm so sorry to hear that, Wendy, and thank you for sharing that, the many forms that care rationing takes and why we have so much work to do, right? Is because people have devalued their own lives and won't necessarily advocate for themselves and won't say, hey, this is care rationing. And we need to be reminding each other of the value of our lives. Shaya says, is the survey only for people in Western states? No, it's for people everywhere. We have been talking primarily about Idaho and Alaska because those are two key states that have instituted crisis standards of care. But the survey is for people everywhere. Okay, and I see a question from Karen. Go ahead.
Yeah, it's really alarming to hear that advanced directives can be used to, without much exploration, be used to deny care. And I never thought of advanced directives in that way before. I think of them as it's possible to, especially if you're working with a particular person who is going to step in for you, to help that person to understand at what point you would not want resuscitation, not a blanket DNR. But now that really worries me. How do people approach advanced directives without just shutting the door to continued life?
Do any of our speakers want to respond to that?
I think that it's important to be as specific as you can be, because many advanced directives are simply going to a particular, like, I don't want this kind of care. I don't want the violence of CPR, perhaps there's something, and that's a personal decision. But you're not thinking that I don't even want to get to a hospital, or when I get to the hospital, the most common type of treatment won't be administered to me because I have a DNR. But I have to say that even if you are specific in your DNR, in the kind of situation where the crisis standard of care is triggered, it's generally very chaotic. And it seems clear from the things I've read that doctors and hospitals are not necessarily going to the medical record, anyone's electronic health record, and checking what the DNR actually says. And I remember last year, during some of the height of the crisis, giving this advice to someone who was asking, what if my sister has to go to the hospital and I'm not sure, they won't let me in with her, I don't know what's happening. And the advice I gave was like, write on her body, I want treatment. Which seems really, really stark, but that's something that should be clear and absolutely present. Something that didn't rely on the hospital following normal procedures or taking the time to go to an electronic health record or read through your DNR.
Thank you, Sylvia. We have a couple more questions. Or are there comments? Are there ideas on how we can take action? particularly, I know there's a lot of people here who do not live in states where we know there's care rationing happening. So ideas on what can we do?
This is Mel from Idaho again. I would just really suggest, I think one of the things that's been the biggest detriment here and the hardest thing to find is that there isn't data collected on people with disabilities. Like they don't record that at the hospital. Like there's no box to check. And you know, in some ways that's probably a good thing. But when it comes to seeing who's dying, we don't have that information because it's not collected. And so it seems to me that that would be something good to push for on a national level is that collection of disability, you know, as far as for people, especially people who die, like we need to know. Like we know in Idaho, approximately 20%, 26% of the deaths, reported deaths, occurred in facilities across a variety of settings, but primarily nursing homes, assisted living, and ICFIDs. And so, and the number in Idaho isn't huge because we're less than 2 million people in our whole state. But it's huge. It's huge to the family. It's huge to the family that lost a person. And so I would just think pushing for better data collection, and along with the rest of the demographic information that's collected.
Thank you, Mel. I see a hand from, I see two hands. I'm going to go ahead and share a couple announcements, and then we'll take a couple more questions since we have to wrap up very soon, unfortunately. So I put a survey in the chat, and I will share that out over email. I hope that folks who are on the phone do have email. If not, please stay at the end a moment, and we'll make sure we can be in touch. If you didn't register for this call with your email, then make sure you stay after so we can be in touch. So the survey is very quick. Please do it right now. It should take you about 2 minutes. And basically it's check a box about how you'd like to take action so we can be in touch with each other afterwards or know how we can really follow up on this. But you know, that's what the Organizers Forum is all about, is not only how do we learn about the issues, but how do we organize people in disability communities and other marginalized communities to take action. And yes, somebody said, are there ways that people interested in the actions suggested here can coordinate? So yes, through that survey, we will make sure we email and figure out some of those ways to coordinate. And if you have other ideas, you can put them in that form as well. A couple of slightly unrelated things that I wanted to share. Speaking of COVID, Senior and Disability Action, I believe in coordination with Detroit Disability Power, is going to be working on a cohort and a training series for people with long COVID or other new disabilities or newly diagnosed disabilities. And so we're asking people around the country to share this survey, and it's bit.ly/newly ill or disabled survey, with each of those words being capitalized, newly ill or disabled survey. So please share that. And then, as I mentioned, this is part of the Organizers Forum, which happens every month. It's always on the third Tuesday of the month. I don't have the December date in front of me, but the third Tuesday, same time, 10 a.m. Pacific time, 1 p.m. Eastern time, usually just 1 hour. So please mark your calendar on that. Okay, so in our last couple minutes, let's see, who do we have questions from? I believe I saw Hector. Hector, do you still have a question?
Yeah, thank you, Jessica. This is Hector Ramirez. I really thought it was very important to perhaps offer the social media campaign to really get some traction, either both in policy for protection or definitely to increase data collection. But you know, we're a year from where we were a year ago. Many of us experienced the consequences of medical rationing in our family. And some of us I lost my brother slowly through that. You know, his body just slowly gave up until, and you know, so it personal experiences really highlighting the human factor, both of family members who have survived and also those individuals who have survived having gone through it. So I really wanted to just offer that as an idea. I definitely would be willing to be part of that, because this is definitely something that is gonna again flare up as we go into the fall and winter surge, which we will have. So thank you for the work that you're all doing.
Thank you so much, Hector. I also want to call out, there's been interest, and we had another organizers forum call on remote participation. And Hector reminded me as he was talking about things flaring up again, is that people keep saying, oh, we're going to be back in person soon, at least here in California, people keep saying that. And recognizing how complicated that is in so many ways, and how being able to participate on video and phone, while it can be terrible for folks in terms of the lack of digital access and equity, can also be more accessible for some folks with disabilities. So, so let's be in touch about that issue as well. And I think we have a question from a 717 number on the phone. Someone on the phone have a question? Hit *6 to unmute yourself.
Yeah, comment, not necessarily a question. So there's some great complexities in what we're talking about. We can go to utilization in hospitals. So insurance companies, doctors can't necessarily even treat the way they want to treat because of utilization. We have that complexity. We have the complexity of needing advanced directives. And then depending on our condition and what happens, to have really deployed that advanced directive that we really couldn't think out because think the whole thing out because the condition occurred in a different way than we expected. So that's another fluid aspect of it that it's very hard to approach, much less the fact that we don't have a national coalition of citizens with disabilities that has a PAC, and we're buying things at the table nationally and then in the statewide. We need that voting block to get the voice. So those are a couple of the complexities of it, comments of, until we tackle some of those real issues, I don't really know that we're going to get a handle on it, because with underlying conditions, they don't really know how to address us. And if we don't know our own selves, we don't know our own minds and our own conditions, then realistically, how can we expect a lot of these doctors to do the things that we want them to do? And in regards to all the complexities that they're put in, like I said, like utilization, insurance companies, and the whole rest, it's very complex. Who's going to tackle that? Thank you.
Thank you very much. Appreciate that comment. Well, I'm sorry that we have to end. Huge thank you to everybody for being on today, particularly our speakers for putting in their time, not only today, but all the work they do around this issue and standing up for marginalized communities. Reyma, McCoy, McDeid from Nickel, Silvia Yee from DREDF, Mel Levitan from the Idaho Silk, Doug Tully from the Silk of Alaska, and Brandi Senziak from ILRCSF, FLAIR, and the Nobody is Disposable Coalition. I realized that was a lot of letters for our interpreters. And huge thanks to our ASL interpreters, our Spanish language interpreters, and our captioner, and all of everyone's reminders and patience on access of all types. I see there are, we now have 14 survey responses, but we've had over 100 people on this call. So please fill out the survey, even if you're not sure how you can help. Just let us know if you do want to stay connected. And the recording will be on Facebook. We'll have it up on YouTube as well. And we will follow up by email to share information from the chat and ways people can get involved. So I think that that covers it. And someone reminds us, please share the care access surveys widely in English and Spanish. That is the single most important thing everyone can do right now or later today or tomorrow. Send it out by email, send it out on your social media. Let's really make some buzz around getting this survey out widely so that we can get those stories and really show people that something needs to be done. And I appreciate Bill Kenyon says, this is so strategic, right? The idea of today is not only to learn about the issue, but to figure out how we can take action. So thank you to everyone for being here, for addressing this, for speaking up for all of our communities. Take care and take action. Goodbye.